Hello, my name is Dr. Carter. Today I would like to talk a little bit about biodefense and public health integration. And we'll begin to talk about how do we bridge biosecurity, community health, public health, and how can emerging technologies both in biodefense and public health be utilized to drive integration. This is the agenda today. We'll talk about some of the fundamentals. What is biodefense? What is public health? We'll get into some of the threat landscape. We'll talk about some of the current architecture, integration, specifically surveillance, preparedness, and response. And then we'll look at how some technologies such as robotics and automation, AI, machine learning, how these capabilities are actually being put together in order to provide a more robust biodefense, and public health infrastructure. As you can imagine, post-COVID and even prior to COVID, much of the ways that we addressed an emerging biological threat, either intentional or unintentional, vice is a typical public health response. And we typically think about more public health driven by communicable and non-communicable diseases and chronic disease, whereas biodefense, threats are typically driven by more we typically think about is bioterrorism. So, what is biodefense and what is not biodefense? Biodefense is really, when we think about it, is capabilities designed to prevent and detect deliberate, accidental, or naturally occurring biological threats to humans, animals, environmental health, and I will also include into that agriculture as really the fourth pillar of human, animal, and environmental health, and we include agriculture in there as well. And it includes the policies, programs that are all bundled with the capability. A lot of times, the policies and programs are forgotten about, and we only think about the capability to prevent, detect, and respond. But the policies and how we leverage those capabilities, the programs in place to allow us to have the very, very important aspect, the human in the loop, and we'll talk in future how much of that maybe human in the loop will be driven by autonomous systems, robotics, and others, machine learning, AI, to reduce the need for as much human in the loop. But currently, we are focused again on policies, programs, capabilities. So when we think about prevention, what we're typically thinking about is threat reduction. So identifying, to understanding, characterizing what's the threat, what are we talking about, what are we dealing with, and then the biosafety, biosecurity, and the deterrence, right? So deterrence is all bundled together. How can you prevent individuals from doing deliberate? How can you deter individuals with appropriate training from accidental? And then naturally occurring is naturally occurring. That's typically the human, the animal interacting with the environment, or the human, the animal interacting maybe with the plant. But is that milieu, that environment that sometimes we don't have as much ability to naturally disrupt? There are some ways and barriers that we try and put in place to prevent that natural biological threat from attacking humans. Sometimes that's various insecticides, that's various barriers that we try and place between the human and the vector, the bug, whether it's a virus, bacteria. There are ways that we try and do that, but what we're really talking about again is being able to do whatever we can to understand the threat and to do as much as we can to deter and eliminate the threat from encroaching within those populations. And then there's going to be times when either deliberate, accidental, naturally occurring actually not move from basically prevention to now it has now it's not only a threat, it's an actual event that's occurring within one of those four systems. So one of the things we have to do is be able to detect that as fast as possible with early warning systems. Sometimes it's diagnostics at the hospital or outlying clinics, but then there's also surveillance systems to include various types of sensors that can either be standalone point sensors. Sometimes the sensors are driven within a hospital setting. Sometimes they're out in the community. There's a whole variety of surveillance systems. Sometimes it may include even video data of interactions of humans to understand. Specifically, we're trying to do tracing or determine who may be infected. So there's a whole variety of systems that exist, and we'll talk about how some of the advances in machine learning, AI, and autonomous systems is driving some of that capability in a different direction. And then we typically talk about response. So after we detected, we've identified that some folks may be infected. We get a, a basic idea of the magnitude, and then we basically have to focus on the overall response. What countermeasures do we have? What countermeasures do we need to develop? And then ultimately, how do we recover from this particular event, whether it's, again, deliberate, accidental, naturally occurring, regardless of where it came from, whether it's bacteria, viral, we are focused on getting back to normal. And so public health, so now we've dealt with biodefense. Now we're talking public health. So public health focuses on protecting and improving health of the entire population through education, policy, research, and organized systems of care. So as you can see, there's definitely some overlap. There's definitely areas where public health will benefit from some of the systems that's traditionally within the biodefense aspect of this interactive system. But again, on a day-to-day basis, there's a distinction because often resources are limited. So you have to basically focus on what your most likely aspect that you'll encounter and how do you leverage that to basically manage, in this case, the overall public health infrastructure with limited. But when you evolve to a change in biodefense posture or you enter into that detection or recovery phase, the public health aspects, which are listed here, population level focus, the community over individual treatment, the data that you typically and the systems you have that can actually do community health well will also allow you to enable you to do biodefense well. Disease surveillance. So this is simply the difference between biodefense and public health surveillance. Disease surveillance is really what diseases, what systems are you tracking and monitoring. As I mentioned before, some of the sensors may be different, but the overall process and ability to monitor large amounts of data will definitely help you out. And we saw some of that specifically as Johns Hopkins doing with the COVID tracker. They were able to leverage some of their existing systems to be able to provide a robust dashboard. Emergency preparedness, again, we saw during the pandemic and historically when there's a need to turn on emergency preparedness to for emergency preparedness to switch from, say, public health posture to a biodefense or bioresponse posture, pandemic posture, having robust planning and health for health emergencies, you're able to leverage that because you may enter into a more of a crisis, a crisis situation. And then the overall, what we typically think about as health infrastructure, your laboratories, your workforce, your supply chains are all things that you're basically addressing on a day-to-day basis to just do basic health care. But what we noticed and we know will occur during a pandemic or during a crisis is that your laboratories, your workforce, and your supply chains will be stretched. So where does biodefense meet public health? Surveillance networks, as I mentioned just now, workforce readiness, workforce posture. Unfortunately, doing these types of emergency events where you're stretched thin, doing large portions of geographical area, and where your laboratory capability is really designed for the day-to-day type routine and your supply chain and your overall, how do you basically communicate the risk in a way that allows you to preserve as much of that capability? And then how do you deal with the overall community resilience? Because on a day-to-day basis, public health may deal with some crisis, but generally not to the magnitude that you would expect to see during a pandemic. So why integration matters? Because what we know is that there's a critical window, whether it's 72 hours or 96 hours or 48 hours. There's definitely a critical window. But we know that critical window, and that's going to be specific a little bit to various types of diseases. But much of how we can deal with that critical window for a bio attack basically matters. So we go back to the public health and we go back to the bio defense and we look at all of the infrastructure that exists within that framework. We know that the ability to basically turn that on and switch from routine public health to we're in a crisis, being able to do that plays a critical role. We also know that there's a lot of money that's spent on biodefense, and we also know that there's a lot of federal agencies, state agencies that actually work together to actually deliver that capability. So there are parallel systems with overlapping mandates, overlapping funding at the state, federal, community level, but it can be fragmented, which can create some blind spots. So everybody's working in their silos, and when there's an emergency, there's a convergence. The more that you can move from fragmentation to integration, that's what's going to result in saving lives and have a more coordinated response versus one that's continuing to focus on what their own individual response capabilities or routine capabilities are. So surveillance, monitoring, and really not doubling down on resources such as adding more sensors. There's always some sensors that are on the shelf. It's always people that are in reserve. There's always some capability that can be applied, but the integration and the fragmentation really occurs on when are you able to know that you're under attack? And that is the key word. When do you know you're under attack? And these are just some historical context. These are situations where we either knew immediately we're under attack, or we basically figured it out, or maybe internationally there was some threats, like for example, the Ebola outbreak, the COVID-19 pandemic. So these are basically either real world bio events or posture changes that led to shaping biodefense policy or other aspects of it. So when we think about biological threat landscape, sometimes we think about naturally occurring. Think about deliberate weaponized, dual use research, gain of function studies, synthetic biology, gene editing, laboratory accidents. Again, and then we think about at times global health security. And when we think about these, it's we're only as good as our weakest link. So we know that there's a whole range of health systems that exist within the world, and some countries have robust healthcare systems and some not so much. But the ability to basically collectively work together despite where those weaknesses are is just fundamentally critical to being able to drive the appropriate response. So what are some of the critical gaps? We know that globally there's siloed data systems. All data systems don't talk together for a whole variety of reasons beyond the context of this talk. We know there's workforce shortages. That there's only a limited amount of money, a limited amount of people, a limited amount of ability for us to dedicate basically people with the expertise at the state, local level when there's other things competing for those resources. And so being able to identify where those workforce shortages are and then being able to basically pull people from other areas to be able to augment those workforce shortages, at least in the early stages of the pandemic, is critical. And that way you create a front line and you're not a front line that's fragmented or a front line that's not able to provide that initial response, but being able to pull people to be able to support that critical window. Funding fragmentation, there's always competition for resources. I don't need to tell anybody that there's always competition resources. And then as a result of that, generally we are developing medical countermeasures for the last event. And, so you have an event, everything is ramped up, and then you're creating countermeasures, and then the thrill, the glory, the beauty of what's going on kind of goes away, and then folks want to shift resources or just priority change. And we saw basically because of the magnitude of the COVID-19 pandemic, there was a convergence. There was, okay, everybody stop what they're doing. We're going to get after this. And we were able to basically take and generate surge capability, manufacturing, and everybody was focused on let's getting rid of the pandemic, into the pandemic. And we saw multiple industries come together to develop testing capability, to develop multiple types of vaccines, multiple types of convalescent plasma, multiple ways to basically reduce the spread and reduce the overall burden of disease. And then it takes time, and unfortunately, during that critical window, you don't have a lot of time to deal with communication issues. But the bottom line is, without having a unified risk communication framework, then which again is not utilized on a day-to-day basis. You dust it off the shelf, but basically, and then you try and inform people without creating public confusion during the crisis. That's a major, major challenge. So when we think about a unified framework for biological preparedness, what we typically think about is prevention, detection, and responding. And we've already hit on this, but I want to specifically mention the response, the coordinated response is actually critical. So one of the critical aspects of being able to have an appropriate response is share data platforms and then exercising those periodically, knowing who's in charge with a unified command, and then having feedback loops and common standards is critical to that response. It's critical to the prevention and the detection, but normally you're doing that prior to the event. The reality is that there's going to be some degree of disease that basically ensues. However, it's critical to be able to identify those and have an appropriate response as soon as you're able to detect it. So integrated surveillance is extremely important, but can have some weaknesses. So, given that you know that there's probably you won't be able to prevent everything, you won't be able to detect everything within that critical window. You're gonna find yourself in response. So, as soon as that pandemic or event, biological event starts, and you recognize that we have moved from prevention to now we're in a detection and medical treatment posture, that's the time to really begin to work on your coordinated response. And so, current state, there's a whole variety. I won't get into those. An integrated vision, basically, ideally, this is the utopia. You got all your data basically talking across systems. You got real time AI powered anomaly detection. You got gene sequencing. You have a One Health integrated model where the human, the animal, you're able to basically fully understand what's going on. You got predictive analytics for early warning, and everything is fully integrated, and you are operating with an integrated surveillance model where the human doesn't even have to recognize that we've shifted from a public health posture to a biodefense posture. The system is automatically pivoting to scale based on real-time anomalies that have been detected. Data are uniformed, and your posture to address that event. And it allows you to home in on that 72-hour window and solve the problem by managing the resources. It doesn't require a human to in the loop because often the human is like, are we quite there yet? How do we know we have enough data? How do we know? because at the end, it's going to cost some degree of public health. So if you think about what did the pandemic cause as you shifted resources, you stopped doing routine surgeries. Some people died as a result of chronic illness. Some people had delays in cancer diagnosis, cancer treatment. But the system decided, okay, we're in a situation where if we don't maximize resources, reduce exposures, and utilize the clinical staff to solve the problem at hand, we're going to be in this pandemic a lot longer, and the all-cause mortality is going to just continue to be out of hand. So as a result, humans eventually came to that conclusion, but a fully integrated system would not require the humans per se to achieve this. That will be the vision. So there's no silos. Okay, what failed? So what failed? Initial testing, debacle. There's PPE, supply chain, inconsistent coordination at multiple levels, delayed data sharing between agencies across the spectrum, and in fact, fragmented risk management. And what worked well was we're able to basically, definitely, we saw acceleration due to heroic efforts within the government, multiple governments, industry partners, just medical countermeasure acceleration. We saw mRNA platforms just become transformative, wastewater surveillance, gene sequencing, a lot of technological advancements just happened. Some stuff that was on the shelf was off the shelf, making a difference. We saw communities transform. We saw community workers pivot from purely public health. We saw laboratories that were designed primarily to do routine testing, ramp up, and now those same workers are actually doing non-routine bio in PPE, creative ways of repurposing PPE. It was all hands on deck. Just amazing when you look at the integration that occurred. The idea would be if, but some of it was decision making by humans. The fully integrated autonomous would allow you to just go, you wouldn't even really know that you're in that posture because the system has basically identified the anomalies and is already used the resources to begin to address it. That will be amazing. So, what does it look like? Robotics and biodefense, autonomous sampling. Okay, where you're not really having to put humans in. The robotic platforms are assessing in real time, reducing human exposure. You letting those humans do other things that we're not having to put humans in a potential risk environment and then determining, oh, maybe you've been exposed, so we got to put you in containment. Lab automation. So versus having humans sit there and fill wells and determine, now you have lab automation, high throughput robotic sampling, 24/7 diagnostic testing at scale, critical surge capability during outbreaks, drone surveillance. There was some you wanted to basically have an idea of, okay, how are people moving? What are some of the, you know, what is being delivered? And again, being able to basically use, I can't, everybody is fully aware of this, but utilizing drone surveillance and being able to utilize aerial biosurveillance is going to be critical. And then clinical robotics, again, telepresence robots that can actually, if necessary, dispense medicine, automated decon. They can basically, versus having the nurse have to go in, or the medical assistant, or the doc, multiple clinicians or clinical services having to go in and triage patients and interact with patients. Much of this would basically be driven without human to human contact, reducing the need for a lot of PPE, reducing the need for unnecessary quarantine and exposure of the human. So much of these systems exist. We just have to basically employ those, and hopefully we're able to employ those before a pandemic. But there's some fear, obviously, job loss and other aspects that's beyond the scope of this presentation. But you're probably thinking about that. Future of robotics. I won't go through this entire slide. You can take a look at it. But next gen autonomous systems for health security. We begin to talk about automated PCR, automated sequencing labs. That's in the near term. Wearables, I'm wearing two of those now for biosensing. In fact, both wearables have a beta version of being able to detect anomalies, and so it's constantly collecting, consistently collecting PPE, algorithms running off the PPE, heart rate variability, temperature. All those basically are known ways to be able to assess and manage physiological variables that can actually lead to some degree that you've been exposed to something physiologically is different about what's going on in your body. Today's technology can't tell you exactly what you've been exposed to, but it does give you some indications that something abnormal is going on physiologically. So if you begin to see the uptick in those types of data, especially they fully integrated with an integrated vision, um, without infringing on individual rights, which is something we always concerned about, but being able to utilize the data for its intended purpose to monitor what's going on within the environment. And then we get in the long term, now we're talking nanobots for in vivo detection, autonomous systems for quarantine operations, and molecular scale medical countermeasure development and manufacturing. So that can actually manufacture 24/7, again, not being relied on humans to availability of humans. So what does this look like? AI machine learning, predictive surveillance is on the rise. Drug discovery, repurposing drugs for optimizing around other conditions, genetic analysis, decision support, using machine learning powered by robust terabytes of data to instead of humans having to analyze the data and determine what's the impact to policy. It's truly data that's driving the policy that's impacted by real-time monitoring. So the policy is basically updated in real time to drive changes in posture. So we think about predictive intelligence, how AI transform early warning systems. So if all of this data that's currently, I would say, in stovepipe format, where you have clinical, your electronic health records, thousands of electronic health records, stovepipe, different types, different systems. You can go on and on. Wastewater signals are there, okay, but not fully integrated. Your genetic sequences or genomic sequencing, all of that is being collected, but not necessarily being fed. Social media, sometimes it's basically driven by data, sometimes it's driven by hearsay or rumors. And so, how we can begin to think about this is with some deep learning, time series, and basically federated learning. So, what we can actually take is AI um, machine learning engine, feed data that can then provide in real time outbreak alerts. Okay, where outbreaks occurring, everybody can see the same data. Risk heat maps. So, what are some higher risk areas in real time evolving as conditions pop? And that way you can apply all your resources. So you got limited amount of resources, and that way you're applying the testing, you're applying the resources, emergency services to where you actually need it. And then at the end, you're making policy recommendations, not real policy recommendations for entire counties or regions, but you're making policy recommendations that minimize the impact to individuals, minimize impact to the economy. It's more nuanced than what we actually have observed in the past. And I think that's going to be critical for us to basically take any pandemic or any event to the magnitude of COVID-19 seriously, because one of the things that the after action reviews is that it was very, very rough on the economy. So what we could easily see is that we could be in a pandemic situation, but due to not having granularized data, not having data where we can actually look at how are some of the clinical data, some of the measurements we're making out there, how is it driving? Is it appropriately aligned with resource allocation? Where can we assume some risk? What are the policy, financial policy, healthcare policy, public health? What are all those policies come together to make informed decisions based on predictive intelligence. And so, also, there's the aspect of AI accelerated countermeasures, being able to utilize molecular design, manufacturing AI around clinical optimization, being able to take capabilities, identify novel drug targets for pathogens with and without existing drugs or medical countermeasures. So, how do you repurpose some of those? And today, the success rate is low. What we expect AI enhanced medical countermeasure development will greatly have higher targets at a fraction of the cost and a fraction of the time. So what we'll see is public health, robotics, AI, machine learning will all converge, where your autonomous sampling will allow you to get to genomic analysis, drug discovery, decision support, and then allow you to basically take your surveillance systems, pivot those to be able to support those systems that are prioritizing it. So the robotics, machine learning, predictive analytics is driving how do you get the most out of your surveillance systems? How do you get the most out of your workforce capacity? And ultimately, utilizing those data to drive risk communication and community resilience. So that way you actually have data that's driving how the community feels and the information they receive about what's going on. And this becomes a continuous, intelligent defense layer. So there's always some challenges. There's ethical and governance challenges, algorithm bias, data privacy, equitable access. There's a whole you can spend some time with those, but this is some of the barriers at times that prevent us from being able to do what we need to do. Workforce, I won't spend too much time, but we need to basically have a workforce that is ready to be able to utilize these. So we're talking cross-domain training where, your epidemiologist is literate in AI, robotics, and so a lot of cross-pollination, a lot of this will occur with exercises. And we also expect a huge decline in workforce to be able to do this. So recommendations, if I was king for a day, these would be some of the top recommendations. Bottom line is that at the local, community, state, federal level, there must be some sustained multi-year funding to basically continue to invest over time. That way, when you have a major catastrophic, when you're in crisis, when you're in response, when you've blown through prevention, and surveillance is basically feeding the models, if without actually having a sustained investment, it makes it difficult. And then just modernize and basically have a framework and a system that allows the inclusion of robots, inclusion of AI-powered network systems. So some of the key takeaways, I think I hit on most of these. Robotics and AI are going to be force multipliers. That's going to allow us to close some of those critical gaps in detection, response speed, to be able to make sure we're within that 48, 72, 96-hour window. And bio threats don't respect borders, right? So, and our defenses shouldn't either. So, really, collaboration, specifically between local, community, county, state, and then the federal, and then interacting with whoever we need to outside of that framework. Thank you. I appreciate you listening to this chat tonight, specifically around biodefense, public health, robotics, AI, machine learning. Thank you.